All right, thank you, everyone. There's plenty of room up front. Ah, okay, well, good afternoon. Welcome to our breakout session, Transforming Healthcare Delivery on Hawaii Island, Innovation, Access, and the Future of Community Wellness. I'm Carrie Shintaku, Vice President of Population Health and Quality Improvement at Ohana Health Plan, and I am very honored to be your moderator today. Just a little bit about Ohana Health Plan. We have been serving Hawaii's communities for more than 15 years, from keiki to kupuna, and individuals with complex medical needs through our Medicaid and Medicare programs. We also focus on serving the most vulnerable in our communities, including adults with serious mental illness through our Community Care Services or CCS program. And while Ohana is a small local plan, we are also very proud to be part of the Centene Corporation, a national healthcare leader that provides healthcare coverage for 1 in 15 individuals across the United States. Our Ohana connection to Centene allows us to bring national resources to local challenges while staying rooted in the values and relationships that define our communities. Our Ohana Health Plan journey has been shaped by partnerships, innovation, and a deep respect for the communities that we serve. And today's conversation is about how we, together as health plans, leaders, providers, partners, and community advocates, can continue to advance access, equity, and wellness across Hawaii Island and beyond. We all know that rural living is one of the strongest indicators of poor health outcomes, and on Hawaii Island, those challenges are even more pronounced. Residents here are significantly less likely to report good health, more likely to face physical limitations, poverty, and limited access to care. The impact of rural health disparities touches every part of our community. We have children that face limited access to pediatric and specialty care, expectant moms that often lack prenatal and other support, leading to higher risks and poorer outcomes, adults and seniors that struggle with managing their chronic conditions and transportation barriers, and mental health needs are often unmet, deepening isolation, anxiety, and stress. All of these multiple interconnected challenges show us that improving health outcomes requires more than clinical care. It requires community rooted solutions that address the full spectrum of need. These are not challenges that any organization can solve alone. And again, that is why we're here today to highlight the power of collaboration. And the amazing panel that we have here today is truly a model for that kind of collaboration. Each of the leaders here bring unique lenses and perspective, and together they're driving community based, sustainable change across Hawaii Island. So let me introduce you to our incredible panelists. We have Sunny Chen, the Executive Director of Healthy Mothers, Healthy Babies Coalition, dedicated to improving maternal, child, and family health through reproductive care, mental health support, doula and lactation services, and peer programs for new parents. They also operate multiple mobile clinics that bring prenatal, postpartum, and other needed health and social services directly to our underserved communities. We have Cecilia Sakata, Director of School Based Health at Hawaii Island Community Health Center. She leads efforts to deliver on campus physical and behavioral health services, making care more accessible for our keiki. She has also been instrumental in launching the new Gateway to Health mobile clinic, a collaboration between Ohana Health Plan and the Centene Foundation, bringing checkups, immunizations, mental health care to schools across Hawaii Island, especially in our remote and underserved areas. We also have John White here, CEO of Hamakua Kohala Health, a federally qualified health center serving North Hawaii. He has decades of rural healthcare leadership experience and is committed to advancing health equity. John has recently led the implementation of a resilience hub in Waipio Valley, a tech enabled community health worker supported initiative that expands telehealth access and bridges the digital divide in one of the island's most remote communities. And last but definitely not least, Aya Ram, board chair of Hazel Health, the nation's largest school based telehealth provider. Aya is also the founding CEO of City Block Health, where he pioneered integrated care models for underserved populations. At Hazel, Aya supports Hawaii's Department of Education Here to Help program that offers free school-based behavioral health teletherapy to all public K through 12 students, removing barriers to mental health care and helping our youth address anxiety, trauma, and chronic absenteeism. I'd also like to invite you all to scan the QR code that you see here and learn more about what all of these organizations are doing in our communities. Thank you, panelists, for being here and the incredible work that you lead. So now that we've had a chance to introduce you, let's dive into the heart of today's conversation. I'll be guiding us through a series of questions that explore the innovations, challenges, and opportunities that shape healthcare delivery in our communities. We probably can call for any questions that you might have throughout the discussion. And then at the end, we do want to reserve some time for you to interact directly one-on-one with our panelists as well. So I hope you'll take advantage of that. And with that, let's get started. The first question we would like to ask our panelists is, how do you envision the future of healthcare delivery on Hawaii Island, and what foundational shifts are needed to get us there?
Is the mic on? Okay, great. Hi, everybody. Thanks for coming today. I think when we think about the future, prevention is the focus, right? We want to think as upstream as possible, and really, so many of the models that we're going to talk about today are prevention focused, and then also rooted in meeting patients where they are. And so that's really been an approach that Ohana has taken, and taken the opportunity to partner with so many of the organizations in our community is to find where the patients are, and focus on prevention. So I think that's my take on it.
Good afternoon. John White, Federally Qualified Health Center. As our friends to the south are at Hawaii Island, we're the northern section of the Big Island. So a couple of framing things I think to really put the conversation in perspective for us is that, first and foremost, I think the long range solutions for the country really are to create healthy people. You know, we're in shortage across the country, across all of the islands here in healthcare, and not just in healthcare, but in so many other ways. Housing, food security, and all these things seem to be somehow unraveling the fabric of the system in front of our eyes. I've always believed, and I even feel more strongly about it now, especially after a great morning of hearing the alignment among the mayor and the talk that John DeFries gave us, and hearing Jill Stakuda as well, that it really is something that is not going to happen here. If there was a chance for a place to get together, be clear on common interests across the islands, not just Hawaii Island, but for sure here, that's really something special in the United States. And I hope we're able to do something together, especially in this time of crisis, to teach some lessons to other folks to where they could perhaps do the same thing through their communities. So it's our turn, it's our chance. In terms of the changes, the transformational changes, a couple things came to mind when I was studying up on the questions that we were posed for the panel. One is partnerships are a critical piece of this. There's no single organization that can do everything that relates to total health, right? So clinical care delivery is a quarter. Everything else is somehow related to social determinants. And so we tend to think of healthcare, or at least I do, because I was on the hospital side like Dan and otherwise, as clinical care delivery, but the social determinants around housing and food security and transportation are a huge piece of the whole puzzle, and we're not going to be able to drive total health without all that, and we can't do it without partnerships. So with partnerships, we've tried this before. It's got to be the synergy of collaboration that we really have to figure out and compromise. The whole is greater than the sum of its parts, and folks are going to have to do something they might not think benefits their organization to drive something that benefits us all and innovates. And so it's critically important. And to support that sustainably, the financing model has to change, and it has to go toward prevention in the beginning of the processes and all of the social determinants to put in place sustainable potential for people to achieve total health. It's not just about one piece versus the other, or one piece without the other. It's the whole thing. And that's the transformation I think that has to happen. And together, because we really are together, I think we can do it. I really do.
Those are really great points. And I think just to add to that, from a perinatal perspective, I talk a lot about a lot of people put so much focus on the labor and delivery, right? But our mothers are not dying during labor. I mean, it catastrophically sometimes, right? But most majority of our mothers are dying because they're preventable deaths, and it has to do with trauma within their lifetime and the systems that we have put in place, and everything that happens before the birth and after the birth. So everybody's always asking, why is Healthy Mothers, Healthy Babies never going to do births? And I never say never, because I essentially say yes to everything. But right now we're not, and it's because there's a lot of reasons, but because the focus is not just on that clinical moment, right? It's not just the labor and delivery. It's everything. What happened to that pregnant person before up until delivery? And what happens, and what is the community going to do to support that pregnant individual, her parents, her other children, in order to make that family healthy? And it's not about just care for that clinical moment or that one person. It's about everybody in the household. And so, we have a panel of patients that's not just moms and babies. We have kupuna, we have so much reproductive care, we have a lot of teens. It's because we're not thinking about the clinical moment, we're thinking about the family and the unit. And we most certainly don't do it alone. We do it with all of our amazing partners. And I think that's the key. And as we think about how we're going to integrate AI and technology into healthcare, which will help hopefully like speed things along and help our clinicians while they're driving their mobile clinics like chart a little bit faster, so we can, we have to live in the system that we're in and as we improve it. But I think that getting back to the family unit and the root and taking care of the ohana, right? Like everybody, in order to make that one person have a healthy baby, right? Ha- the trauma all the way up until she had the baby, until she got pregnant, and then what happens after: mental health, social support, um, diapers, cribs, whatever it is, all the way through, so that we can have a healthy family unit. I think and then that's going to make the generational impact that we need to transform healthcare.
I'm going to pass this to Aya in a second, but I just want to take this momentum and say that's really why when we partnered for our school-based mobile health unit, we named it the Gateway to Health, because as a federally qualified health center in the community, we really realized the opportunity to, yes, we're on the school campus and we're engaging with students who need healthcare on campus, but as the FQHC provider in the community, it gave us this gateway to health for their entire family. So we may be talking to mom, dad, tutu, whoever's taking care of that student, that we're working with them in scheduling their appointment and connecting them to care. It gave us the opportunity to connect the entire family to care because of who we are as a health center, and open it up. So does the family need other things, behavioral health care for mom or dad, or substance use support? And so that's really where we went with that gateway to health. So Sunny really captured that. No.
Sure. Well, how do I follow all of those? Are great answers. It's hard to go last. Um, I guess I'll share a couple of perspectives. I sit here with probably two very different lenses. I've had two pretty distinct chapters now to work. One was all in community health, specifically very hyper local health. So my last organization that I built was the largest, still is the largest employer of community health workers in the country, and so thousands of community health workers across the country. And I would just echo John's perspective. When I think about Hawaii and the unique opportunities here, we've made it home now for a little while. Our family came and kind of stepped deep into the islands. I think the community health workforce opportunities here, as we think about all the sort of threads here, are just remarkable. And in particular, I think the adoption of telehealth, which is more robust here than frankly I've seen anywhere else in the country, by necessity. But nonetheless, that necessity has led to real invention, offers tremendous opportunity to think about collaboration in very different ways, to John's comments in particular. And then the other chapter is now doing kind of gap filling work. So I came from a world where we were the center of everything, to now an organization at Hazel, which really kind of fills the gaps around everybody else's infrastructure. And so Hazel is very much a last mile delivery program. And I think what's very interesting, kind of sitting from that lens now, looking at opportunity, is you get this very bird's eye view of, frankly, how many kids are still falling through the cracks in particular. And so despite the robust infrastructure, despite robust collaboration, there are kids all over the islands who are just not accessing care in very traditional ways. And I think one of the more I think important considerations there, as we figure out how we build forward, is where kids are choosing to access care. And so a lot of my work over the last 2 years has been work that frankly is in an area that makes me very uncomfortable, which is how do we use AI and how do we let, when kids are directly engaging in AI, how do we think about mediating those spaces safely? As many of us in the room are, I'm a parent. My older kiddo is 13 and is about the most therapized kid that I know. He had a very severe eating disorder. He'll go to GPT every time and say it's better than any one of his therapists. Like that is just what he does and where he gets his support, no matter what I say about it, no matter how much I talk about safety guardrails. And so this is where kids are going. And I just, I'll share a perspective. I have a good friend who just did a study talking to teens and adolescents about where they're going to get their care. And 92% of them, on 11,000 or so kids that were sampled, said their primary point of care is going to be an AI large language model by the time they're 25. And so whether that's true or not, whether that's right or not, it just is. Like, rather, whether we believe it's the right answer as a healthcare system, it just is. That's where kids are going to go. And so for me, there's a really interesting and important opportunity that I think we can actually lead on here, given the robustness of collaboration and the opportunities given the challenges of access across the islands, to really think about how we build a robust framework for supporting kids safely accessing services in those ways, and then probably doing so across families as well.
Yeah, thank you. Tor- yeah. Yes, absolutely.
Is on your mind once you've heard some of the things we were talking about? Quiet. Oh, I can't believe that. Well, let's make it a
Okay.
conversation.
Yeah. Yeah, let's press forward. I mean, there is a lot covered by the panel for that first question: partnerships, whole health, prevention, family, vulnerable populations, how we access care. Um, I do want to delve a little bit deeper, though, on the technology piece of things. And, John, you've been doing a lot in Waipio Valley and remote areas to try to increase access using technology. Um, can you all talk a little bit about how the integration of technology like telehealth um, has redefined what access to care looks like in our communities? I touched upon it a little bit for our youth and behavioral health, but what other technology considerations do we sort of need to think about and as we kind of delve forward?
I can start with an example. So we jumped on the bandwagon pretty early when we started mobile health. Our mobile health units absolutely have so much technology in them. They're all a little bit different. Just a little plug: our poster board that our wonderful midwife Benny sitting over there made has a QR code, and you can virtually tour 2 out of the 4 mobile units. We've got, I love saying this part, so we've got OG Mama. She's our original mobile clinic. And then we've got Big Mama, who normally is serving Big Island, but right now she's getting some upgrades. So we've got Plan B here because she's the backup. And and then the newest and very tech savvy one is she's all electric on. So she's on an electric van, on a GM chassis, and has 1,000 watts of solar and Starlink on the roof. With a lot of other technology, and I wanted to and we call her Mama Mia, and she's on Maui. I wanted to brag about that technology, but also other modes of technology that's new and upcoming. So I'm always looking at like innovative models like MIT and those young entrepreneur tech people all the time. And when remote fetal monitoring was up and coming, we kind of jumped on the bandwagon pretty early. I like adopting new innovative models early because I want to test them out. I love doing pilots. So we started doing it. The challenge was, though, we really consider ourselves an extension of the QHCs and the OBGYNs out in the community. We don't just do fetal monitor on anyone. We mostly have amazing midwives, but they need the referral from the OB out in the community. But then getting that, so we're able to provide the NST, but getting that NST back to the provider, you would think in 2025 it'd be pretty easy, but we were like hand delivering NST strips. So there's challenges there, but it's amazing to think like NST clinics generally do not, for those of you who are familiar with OB care, don't make a lot of money, and they're kind of a money pit for hospitals, right? So, and access to care obviously is a big issue, especially in rural areas. And if you're a mom with, high blood pressure or, preeclampsia and you need fetal monitoring, but you can't get to the NST clinic because you have to fly on a freaking airplane or there's no appointments or you have to drive 2 hours, it's just not realistic. So we're able to provide it, which is super innovative and amazing, but there's still glitches in like the connector piece is kind of what I want to talk about and mention.
Sure. So I think you said something a moment ago, the last mile piece. Like it or not, all of the system's best efforts in execution and science and clinical prowess and all the experience we have goes nowhere if you can't finish the last mile, right? You get all the way there and it doesn't get delivered somehow. So in a lot of ways, especially in rural places, the last mile is a one-to-one kind of experience. That's just the way it is, and it really is that way for all of the different delivery mechanisms, not just healthcare. It is about a person, and that's why I think the community health worker movement has been incredibly important. I'm a CHW myself, and I'd like to thank Chauncey Hariko. Chauncey's up in the front here. Chauncey is our host for Kohala Health Center in Waipio Valley. So he provides this. His family is an 8th generation Kalo farmer in Waipio, and he provides the credibility and the potential for us to go down and offer folks the ability to self-determine in a way that meets what on their home turf. We come to them, and it's a completely different approach. Telehealth is something that can extend over that last mile, and it's one of the more effective ways to do not everything but many things. And what we've done with the Resilience Hub is to put a Starlink transmitter reception device. It will be in a little shed. It's like what is it, like a 10 by 20, Chauncey? And that'll be a place to gather and do telehealth, and actually for those who want access in the valley to have it where it's never been before, solar powered. And it took the partnerships of everybody. Healthy Mothers, Healthy Babies. Penny drove us down. I don't know how. And was it Big Mama? Which one drove down? It was Big Mama. She says it's a Big Mama. And I said, oh, yeah, that's a Big Mama. I'm glad you're driving. And a Vibrant Hawai'i, Ohana Health Plan. We had probably 50 people down there and saw 40 folks in the valley. But so it's that last mile, and it's different approaches to the last mile, like telehealth, but really underlying everything's the partnerships. You just can't do it alone. We have our piece. We do it well. We need everybody else to do the same thing.
Big supporter of large language models. I like to call AL Uncle Al, and I use him all the time. But I also think that, and of course, telehealth. You guys have really spoken to how that can impact, and we use that a lot at school-based health centers. In under-resourced area for providers, we're not going to have a provider at our school-based health center every day of the week, and so we rotate services where it's medical, dental, and behavioral health that rotate through these school-based health center sites. And on the days that a provider isn't present, then the students do have access to telehealth services. So we can't highlight or speak enough about how helpful that is. But also, I think we don't want to underestimate what other, all these bright and shiny new tools, but there's so many programs and so many resources that are actually underutilizing their analytics programs that exist in their EHR, and just some of the more basic things that are already available to us that we don't need to always have the newest, shiniest, brightest things, but there's ways that we can better utilize the tools that are already available to us to impact care, to help guide our decisions and drive where we're providing care, and use that data and that information to help us do a better job. So big supporter of all the new and shiny things, but also I think we can really step up to the plate and use so much of the existing infrastructure that we have to do a good job.
So agree with everything that's been said. I certainly, the ample opportunities in telehealth and thinking about some of the really sort of novel tools for directly engaging with patients are important. I think to me, actually, though, and to pick up on something that Sunny said, it's the boring things. It's data infrastructure. It's figuring out how we communicate with one another. I think, when we think about, we're doing a lot of work with the Department of Education, not just around last mile service delivery, but also around how we think about supporting them in sharing information across the ecosystem. Because when we think about, in the country, 70% of mental health visits are delivered in schools. That's, as true in Hawaii as it is anywhere else. Like, sit with that for a second. 70% of our kids' mental health services in the United States are delivered in schools. But those schools are largely not, except for special, incredible programs, those are largely not connected with the traditional healthcare system. And so figuring out the data rails, all the ways that we communicate with one another, how we take tools like monitoring in the community and bring it back into the infrastructure of the system is actually some of the most important work, I think. There's really interesting opportunity there. And when I think about Hawaii as a community, we have, I think, a very unique opportunity to build common infrastructure that is actually quite accessible to all. One of the things that I'm really excited about, as crazy as this is going to sound, but I actually think that a lot of the work that is being done around kind of agentic AI and the communication of like a computer to a computer, but by voice for exchange of data is remarkable. It's truly remarkable. And we've been using it a bunch in kind of our internal infrastructure now, where literally somebody that, when you think about all the complexity of building data systems, if you can just have a computer tell another computer what to put into a traditional data field, as crazy as that sounds, it works. And it's much simpler than building, for example, a database that everybody can plug into and have all of their IT teams integrate into. And that is what's happening across the technology world now. Like, a lot of the call centers that we all call when we're calling a different company, we're not talking to humans anymore. We're talking to computers. And so figuring out how we as healthcare get comfortable with that infrastructure, get comfortable with all the HIPAA protections, or in schools, the FERPA protections, but also start to embrace the fact that this can drive a lot of efficiency in that collaboration, I think is going to be very important. I don't know how that's going to work yet, because I think there's a lot of trust to be built. But actually, that's what gets me excited about Hawaii, because it is actually more a trust problem than a technology problem at this point. And this should be a place where we can build trust.
Thank you. And I think, building upon that, we all talk about collaboration, partnerships. From your perspective, what makes cross-sector collaboration successful, especially in rural and culturally diverse settings such as the ones we live in?
I think you guys should go first.
I'll keep it really simple. Humility. I actually think that's what it comes down to. Is it is not more complicated than recognizing that, sort of the history of healthcare, less so here than other places, but even here to a degree, is that it's one of the most competitive, turf war oriented, try to win all the spaces kind of places in our society. And in particular, when you think about cross cultural and cross sector collaboration, humility is where it's at, right? The reason the community health worker model is so important is not just because of the employment models, not just because of last mile, but it's actually the most culturally accountable and culturally collaborative model of care that we have. And so I think what sits at the root of that is recognizing what we do and don't know, what we do and don't understand, and being able to step back and out of the way. I think that when you do that, actually the system starts to fall into place, because the pieces right size themselves. The leaders step forward in appropriate ways in any given community, which, in a small remote town might be us, in Kona is not us. And so really recognizing that the system will take care of itself to a degree if we listen, I think actually is kind of all that you need.
We spoke about this during my little lunch breakout session that me and a couple people were sitting, and we were talking about kind of that perspective of competition and collaboration. And so if we really take our cues from historically the systems that were in place in Hawaii and collaborate and own up to what we're doing and say what we're good at and what we can't do, kind of just how you were speaking, what you were speaking about is really shift our mindset from competition to collaboration. It's needed, especially in rural areas. And that's really why we're all sitting at this table, is because we have all recognized that it isn't anything that any one of us can just do, that there's more than enough work to take to do in our community, that it does have to come from a place of collaboration.
So I think I agree with those things, and I mentioned it earlier on in my first comments. I think the ability to compromise for the collective good is critically important. I came back to Big Island from a community in North Central Washington State. There were 3 hospitals that were about 20 miles apart, and everyone was struggling to deliver babies. It was, I mean, from the 24/7 anesthesia coverage, the surgical crew, and to maintain competency in a low volume situation. But nobody wanted to give it up because that's part of what makes your hospital a hospital, right? In the eyes of the community, really difficult. But we got all 3 communities together, and folks reluctantly came to the conclusion that the consolidation point needed to be one of the 3 hospitals. And so we did that, and we got past what, if there is such a thing in obstetrics, a break even, to make the sustainable service possible and real. But it wouldn't have happened had folks not said, you know what, it's way better to do it this way. Doesn't benefit us directly, but it will, because we're here for the people and it benefits them. That's how we get the benefit. It wasn't on the balance sheet or the income statement. It really is about, that community good and the social good. And it will take that kind of compromise. And I know on Hawaii Island we've tried that. I mean, it's been, whether it was the Beacon community. I don't know if folks remember that. I mean, there's just been numerous learning experiences about what didn't work, and let's try not to do that again. And it typically came down to folks that were trying to advance their particular, and with good reason and good intentions, their potential function or their contribution to the whole system.
I would say, I'll be the first to say it. The nonprofit sector, especially in healthcare, there's going to probably be, in the next couple of years in this current administration, days of reckoning where we will be forced to collaborate more than we already do. And I will be the first to admit in this room that it's not always the case. So, we want to, like in Hawaii Island, I think we do a really great job of collaborating between nonprofits, but the sector will have to consolidate. I think that's just the reality of what's going to happen. And I think we'll come out on the other end better, and we will be able to utilize the coconut wireless and all the amazing work that it was proven when we were in Maui, it worked. The coconut wireless is strong. And so I think being embedded in the community, investing in the connectors like the community health workers, the doulas, I think that's what's going to make the difference and help us on the other end.
So I spent a lot of time in state government earlier in my career, and on the other side of the country, and I've been a part of 2 different systems that have had to go through significant consolidation, as Sunny described. One was done to the system, and it was very reactive, and one was done affirmatively with intentionality, recognizing that that consolidation was going to be required for very different policy reasons. And you can guess which one worked well and which one was really bumpy. So I think it's a really important and really powerful point that no matter what we want to believe about the policy ecosystem that we live in, consolidation will happen in both nonprofit and for-profit settings. It has to happen. And so I do think that building intentional plans and figuring out what that system should look like, where folks should step forward and step back, and how we kind of center on the right services as opposed to the right entities is going to be a really, really important part of this conversation over the next while.
Yeah, thank you. Do want to talk a little bit about community voice. How are community members shaping the direction of what we're doing? And what does meaningful community engagement look like in practice?
Some examples, we work with, decision makers. Department of Health might host something, and we have a lot of community. Sometimes nonprofit is considered community, but I don't consider that necessarily community. It's inviting the parents, inviting the children and the youth to come and speak, but also giving them the platform, giving them the strength to do it, and providing childcare, making sure our doulas are there to provide that in those meeting spaces, and really uplifting their voices, I think is really important and a core part of what we do every time we're we're talking about systems transformation. And I do see it in more and more in the last couple of years, especially after COVID. You know, decision makers intentionally trying to ensure that we do have community voice that way, and ensuring that the parents' voices are heard. We can always do better, but I do see us moving in that direction more and more.
For the school-based health center, I think it's really about us building relationships with the partners that we're partnering with. Like, we can come in and say, "Hey, we're going to give here's our menu of services that we're going to provide at a school-based health center." But unless we're actually, you know, meeting with the teachers, for us, it's meeting with parents, but also meeting with teachers and school administrators to find out what are the specific struggles of their school. Meeting with our other community partners to say, "Hey, what are you guys doing in this space?" So we're not duplicating services, and then really just taking the time to not just hand a business card or say oh, here, this is my title and this is what I do, but take time to sit at a table and learn about what everybody's doing, and learn about what the real needs are, and actually form those relationships so we really are bringing meaningful services that the community that we're serving actually wants.
I'll actually say, speaking as somebody who came out of deep community engagement, I don't think Hazel Health does a very good job of it. So it's part of why I'm here. I think that I think organizations live and breathe on community engagement, and I'll just speak frankly and say I think the way that Hazel entered the community here was very top down. It was sort of statewide, deep health plan partnerships, deep state partnerships, very little community partnership, and so part of the reason that I'm so excited to be a part of the team there is actually I think there's a tremendous opportunity. Every student in the state has access to free mental health services, period, full stop. And also, there are many other people who provide mental health services in schools. And like it, to the point of collaboration, coordination, we don't collaborate. We talk to each other, we're all friendly with each other, but we don't collaborate, we don't coordinate. And so I think there's a tremendous amount of opportunity to do better. So uh, for me, it's a really actually exciting moment to think about what that might look like. And if you have a service that the state has made available widely and it's not adopted at nearly the levels that I would expect it to be, that speaks to a problem.
And so to that point, like for our school-based health centers, we go all the way down to like meeting with school counselors to make sure that in our systems, in the school systems, there's tiered support levels to make sure that kids are accessing support at the right level, and they're just not always being referred to the highest level of care, right? So we want to think about how are we using our resources, especially when we're in such an under-resourced area where it is hard to find a behavioral health provider, it is hard to find medical providers, that kids are being referred to care in a tiered way that it's meeting their needs. And so we're not stressing the system when we don't need to.
How's your Celsius holding up? Good. Okay. Penny's got both coffee and Celsius, just by the way. It's an awesome combination. A couple of things. So we are Hamakua Health is a federally qualified health center, and if you're familiar with the legislation that authorizes us, 51% of our governing board has to be consumers of services at the clinic, and there's a requirement for folks to reflect the ethnicity, the social status, social strata, the geography of the people that we serve. And it's critically important because I can tell you, and probably many of us don't know what it's like to be homeless. Those are people we serve. The solutions are best generated from the folks who experience those things, and governance is where that comes into being. And a lot of my experience in Washington State was with public hospital districts. These were folks that were elected commissioners that governed the hospital districts, which often had, every healthcare entity in the whole community was underneath the district. And again, the form of organization connected us absolutely. There was no lack of clarity of mission. We're here to serve the people. They elect our governing board, and then they, from a policy standpoint at the governance level, help us do what's right. And I think to do it right here and everywhere else, we've got to have that connection. That's part of the key for going forward, is really understanding and having the voices of the folks that we serve as part of what we do and how we do it.
Thank you. And I know we want to leave some time for our Q&A and for interaction, but last question, and I'll ask that it just be very brief because there's a lot that we could keep talking about, but what is the one bold action or investment that you believe is essential to truly transform healthcare delivery?
Anybody else? Oh my gosh. Well, I mean, again, so I'm a recovering chief financial officer, just full disclosure, and I'm still not recovered. And that's been a long, long time ago. But this is a little bit of a barrier, but it's also something that I think would be something bold that can be done. So healthcare in the United States, unfortunately, is really focused on the income statement and the balance sheet, and life is lived for better or worse in 1 month increments, and decisions from governance and everywhere else, and because of the financing systems around us, are that's the way it works. I mean, we live in those short-term increments, and we already all know that none of the things we're going to do to drive total health are measurable in 1 month, and they're not measurable in 1 year, and they may not be measurable in 5 years. So to start with an idea and trust in the concept and go and see it through long enough is one of the critical points of all this. And so to do that, we've got to change the root cause behind that 1 month, 1 year focus, and it's the financing systems, it's sustainability. So somehow we've got to find a different payment model to be able to do what we need to do, give people what they need, and drive total health so we don't have these shortages. In other words, we've got enough now to take care of everybody if everybody wasn't so sick, and figure out how all that goes together. But the financing piece is just the core of all this. And to develop a new payment model is the boldest step I think we could take to make things go forward. I think the policy pieces, nurses, physicians, providers, clinicians, they're trained individually to have their own, they know what's right and they do the right thing. The system will work its way that way. We just got to make sure we support it with sustainability. And that's a huge lift. And it obviously hasn't happened really anywhere in the United States.
Thanks for saying it so I didn't have to say it. We love our health plan partners. We do, but we do need a lot of transformation in the payment system. And I really appreciate our partnership and Mana Ohana for taking a big risk, right? I think that I'm so grateful that, Scott, you guys were you trusted us to be like, okay, well, we don't really know what you're talking about when you're saying you want to transform perinatal health and make Mana Ohana the way you want it, but here you go, just do it, right? And we funded our community health workers, our doulas, our overhead, the food, whatever it is that needed to happen, right? So, but that's not really quite, we can't replicate it quite yet. But I think the ideas are there. We just need to get there. It won't be tomorrow. It'll take a long time. One other thing I was thinking about was our children in schools. And I think that instead of this capitalistic model of healthcare just getting bigger and bigger, and our federally qualified health centers just getting pushed to see more patients, and our doctors and providers having to see 40 patients a day, it's just not sustainable. I think that we need to bring healthcare to where our people are at, whether it's the shelters, the schools. That's where we find out that mom is not doing well and can't get out of bed, right? Like the student will tell the teacher, well, how do we take that connector and the teacher, have her or him be able to make that connection and tell the healthcare provider mom hasn't gotten out of bed, right? So it takes a lot of bold movements from the payer perspective, but also from our healthcare system thinking maybe it's not to get bigger and bigger every year over year over year. How do we get more people out in the community? If somebody in rural India gets their vaccines from a community health worker on a bike, like, why can't we do better? Why can't we connect all of our islands together and ensure that everybody that needs healthcare wherever they live gets access? And I think we have the tools, we just have to get there, and we have to go that last mile.
So for the health plan folks, for Scott still here, I saw him. There he is in the back. So we're with this, the United States. Most of the healthcare we deliver is funded by the federal government, in some way, shape, or form, right? So Medicare, Medicaid's half that way, or some government in general. The health plans are not. I mean, everybody in the whole system right now contributes to the fact that it isn't hanging together like it needs to be. And there's no criticism of the health plans or otherwise. They're one of the many partners we've got to have on board to make this work. That's where the data lives. That's where we've got a lot of the analytical resources, the membership reach, all of the things. There's lots of good tools that come through health plans. So that wasn't, if my comments came across that way, that was not what I was intending. I just want to make sure that was clear.
So many bold statements. Okay. Yeah. um, so I'm going to just take the pediatric perspective, right? And so when we're thinking about changing healthcare, this is really where we start. We start with pediatrics. We start just shaping the way that they access care, the way that they engage care. And so I'm going to take this school-based health center and say I'd really like one bold thing that I'd like to see happen is a school-based health alliance in the state of Hawaii. So we can really start to engage kids across the state. I'm here on this island, but it really is something that can change as the nation rolls back healthcare. I think we're doing a really good job of getting it on its wheels and pushing it forward. And so I want to see a school-based health alliance started in the state of Hawaii to help grow this movement and help kids and families engage in healthcare, starting where they are.
Let's do that. Deal. Last, I get the mic last, so I'm going to give you two. Forgive me for it. One, a specific one following on to John. So one of the things that I built a long time ago is we built the first dual eligibles programs in the country and the policy frameworks. I think there's a similar opportunity for kids. So when I think about all the fragmented dollars around kids, when you think about special education, foster care, justice involvement, all the different dollars that flow to kids in very different fragmented systems, and then the healthcare dollars, finding a way to blend those together in a really intentional way from a policy perspective is one of the different purchasing frameworks I'd love to see. And then the other is, I wasn't checking my email, I was checking a statistic on my phone. There are 164,500 people between the ages of 18 and 25 in Hawaii. I'd challenge us to get 10% of them trained as therapists. We can do that. Like, that's actually a very real thing we can do. And we think about job creation, we think about necessary workforce development, we think about our time zone positioning in the country and the ability for people to deliver care all across the country from Hawaii as a base. We should train them at large scale, and it's a very doable thing to do.
Awesome. Thank you so much. Questions? Lauren Kim.
Thank you, Carrie. Hi, Lauren Kim, Department of Health. First, a comment, then a question. A universal keiki insurance program is page 12 on the Department of Health's to-do list during the Green administration, probably the second one. So it's a goal. We're not even starting there yet, but it's a great vision to have. Secondly, Rural Health Transformation Grant. Applications are coming through. The state is organizing. There's 7 big buckets. Of the applications that I've seen, community engagement, which is something my director is very interested in, is really hit or miss. So when we get the 500 million for 5 years or the 1 billion for 5 years, what kind of investments can the state make to really get community engagement out there? We're seeing some really great proposals that are common sense, that are going to be transformational, and they're all dealing with people in this room, which is where things start. But I was really enjoy the last mile comment, when we're doing broadband, all that sort of stuff. And I'm beginning to get concerned that last mile is not going to be there. These are government programs. I'm from the Department of Health, COVID, all that sort of stuff. So, where could some of that money go to get it out there as effective as possible? I mean, we're not going to do 50 contracts with 50 people, but where would a general investment, and feel free to propose this to the governor's website, be made with rural health transformation money to increase community engagement to support healthy outcomes?
My initial response is let's not get to the last mile, right? Yes, of course that's where we are because that's just what the scene is right now. But what kind of system can we build so we don't need these last mile, last minute, they need this instant access, and so that is prevention, right? And so that's the investment.
So I think it's a great answer. I agree, and also recognizing that I think we won't get there anytime soon. As much as I would love to see us getting there, I think two things that come to mind. They're more general. They're not specific to what we do, but that I think are really opportune in particular here. One is if you think about sort of the local councils on aging model. I think there's an analogous model to be built for children. And so when you think about, like upstream of universal payments for keiki, which we should get to on page 12, but before we get to page 12, I think there is a councils on aging model that is actually applicable that I've seen in a few different communities across the country. That to me it's basically parental activation. And when you think about what, where like core community engagement could come from, in the same way that we think about school board engagement and other sort of places where parents may get involved in the system, I think you can create actual infrastructure around it with community nodes. And then the second that I would just think about a little bit, that I think is very different, but I actually think ends up being one of the more powerful community engagement tools is a really, really robust, specifically community paramedicine framework as a state. Community paramedicine specifically built around a community health worker model as part of the ride along team is the most powerful intervention I have ever seen from both a cost and a quality and an outcomes perspective. So the model that I built was pairing a paramedic with a community health worker as your forward deployed team with telemedicine behind it. What it ends up doing is hiring a very powerful community voice, but placing them directly in the healthcare system in a clinical capacity. And so something I would think about.
The short answer is workforce, I think, and if I going along with that last mile theme, I think the folks that make the connection that are the most effective are the people that are in the community, understand the social norms, the way you actually get things done, motivate people to change, to accept things. And the community health worker program and programs similar to that are, at least for now, probably the best link between where we end and where it has to end. That last mile piece is a big deal. And there are rural examples across the United States of folks that have addressed this in different ways. So the state of Alaska has, I think they're called community health advisors, CHAs, that practice in their own very, obviously remote communities in the largest state in the United States. And they're trusted and they do things outside of the scope that we would ever allow anybody to do, probably anywhere else. But the reality is it's either nothing or something, and the something is far better. So I think it's that last mile and trying to get innovative around who it is that does the work is probably the best answer.
Just to add to that, we actually don't have a model in place solid yet for community health workers and the community connectors, um, to have sustainable, like be able to live in the most expensive state in the country with rising costs of living. At Healthy Mothers, Healthy Babies, we cannot function without our wonderful community health workers. But it's a struggle to fund that, and we don't have a payment model or a system to ensure that they're sustainable.
Other questions?
I'll give a little bit of information. So Hawaii Island Community Health Center actually just took our one of our mobile units, our largest one that was located in Hilo, and we have taken it down to Ocean View, and it's going to kind of live there for a bit to create a new community hub. Kind of, it is a mobile clinic. It has 2 exam rooms, and so it's not a brick and mortar by any means, but it's going to be stationed down there for the foreseeable future to try to help improve access to healthcare. And then for the school-based piece, we actually just drafted our cooperative agreement with the KKP complex, Keau Ka'u Pahoa, and those are the schools that are also served in that district. So they will start having access to school-based health care at the schools as well.
So if and I talked about public hospital districts before. So the original district was formed in downtown Chicago because the hospitals that were present there, 100 years ago, withdrew because it just inner city wasn't their jam. I mean, they couldn't be sustainable. There was differences in culture and staffing and all those things. So the community got together in Chicago and said, we're going to do this ourselves. And so they formed a public hospital district that funded the first public hospital in Chicago. And then in Washington State and around the country, that's been replicated, and it's usually now in rural areas because really no one else is able to do what you need to have done, and nobody's as motivated as the people that live there. And so the Washington State model is one of many. There are 54 public hospital districts out of 106 hospitals in the state of Washington. They have taxation authority. They have the ability to issue bonds, and I mean, it really made it there would not be many rural hospitals in the state of Washington without the public hospital district model. And it took enabling legislation at the state level to make that possible. Revised Code of Washington, Chapter 70, Section 44 is the law. And if you're curious about a model, that might be a solution for some of these far-flung rural places that are just tough to serve, right? It's difficult to get providers down to Ocean View and have them with all the opportunity cost of the travel and trying to set up and figure it out. The mobile clinics are probably as good as we can get in the short term, but the longer term solution is something that's got to be a bit more, sort of permanent. And public hospital district model, might be one of those sorts of things.
Right. Thank you for your expertise, your experience, your commitment, and all that you all are doing to improve our community. We do have a few more minutes. I'd like to invite you all to just come and chat with our panelists one to one. There is a break, so we do have some time. But thank you all for being here and for being part of the solutions to help our communities be healthier and be well. Thank you.